Good morning, everyone. Thank you for joining us for this week virtual journal club. My name is Juan Pablo Brito. I'm an endocrinologist at Mayo Clinic and co-host of these virtual sessions. Today we have the honor to have two wonderful speakers, Dr. Sanabria and Dr. Carolina Ferraz. Dr. Sanabria will be presenting the article that he published in Thyroid about the management experience with that surveillance of thyroid low-risk carcinoma in developing countries. And Dr. Carolina Ferraz will be our expert discussant for that article. Before I start the introductions, I would like just for the audience to take a look at the slide we have right now. Is for the World Congress of Thyroid Cancer, just to let you know that the Congress is running virtually and the next session is tomorrow. So if you want to attend the Congress, you can see the link there for thyroidworldcongress.com. So let's start introducing Dr. Sanabria. Dr. Sanabria is a general surgeon at the University of Antioquia in Medellin, Colombia. He's the head and neck surgeon in the AC Camargo Cancer Center, also in Sao Paulo, Brazil, when he trained as a head and neck surgeon. He also had a training in clinical epidemiology and health economics as well. He has a PhD in oncology and currently is the full professor in the Department of Surgery at University of Antioquia, Medellin, Colombia, and is the scientific director of the Center of the Excellence of Diseases of Head and Neck in Medellin, Colombia. Dr. Carolina Ferraz is an endocrinologist and professor of endocrinology at Faculty of Medical Science in Santa Casa de Sao Paulo, and coordinator of Thyroid Nodule Center at Hospital Samaritano de Sao Paulo. With that, I will turn it over to you, Dr. Sanabria. Thank you very much.
Okay, thank you, Dr. Brito. Okay, are you seeing my screen?
Yes, we are seeing your screen, Alvaro.
Good morning. I want to thank the Thyroid and Head and Neck Cancer Foundation for the invitation of this journal club, and also want to thank Dr. Juan Pablo Brito for considering the presentation of this article. It is an honor to be here representing Latin American head and neck surgeons. So I am going to present this article, the experience with active surveillance in thyroid low-risk carcinoma in a developing country, which was published in Thyroid in 2020. First, these are my conflict of interest, and I would especially like to comment that I am a surgeon, so it makes me think all the time about the risk-benefit balance between surgical treatment and other treatments. Second, as I have a training in clinical epidemiology, and I'm also worried about the strength of the evidence that supports clinical decisions. And finally, as a health economist, I'm also evaluating the economic consequences of clinical decisions on patients and the health system every time. As is already known, thyroid cancer incidence has been growing since the 80s, when the wide availability of ultrasound allowed the detection of small thyroid nodules. Some of them later diagnosed as papillary thyroid carcinoma. Most of these tumors were smaller than 2 centimeters, which confirms that most of them were incidental findings in asymptomatic patients. Even more, although the incidence has grown exponentially, long-term mortality remains low and stable. Overdiagnosis has been defined as the detection of early and asymptomatic conditions where treatment does not offer any advantage in the future. However, the problem with detecting asymptomatic and early thyroid tumors is that physicians have to offer treatment, in this case surgery, to all patients, even to those who will not reach any benefit from the treatment, because it is impossible to predict its clinical behavior. This is also known as overtreatment. Specifically for thyroid tumors, surgical treatment involves the risk of complications such as recurrent laryngeal nerve injury and definitive hypoparathyroidism, the potential possibility of chronic support of thyroid function with medication, the aesthetic consequence of an X scar, and the psychological effects of having a diagnosis of cancer. So an alternative to surgical treatment of low-risk thyroid carcinoma is active surveillance, which is supported by some data. Most tumors are incidental findings from diagnostic tests made for other reasons. The frequency of occult carcinoma in autopsies of patients who died of other reasons is almost 30%. And most of these tumors remain stable, and if they grow, this growth is slow. Most experience about active surveillance came from Asia, where the first reports were described at the end of the 90s. And only in the last 10 years, active surveillance was introduced in Western countries such as the United States and Italy. However, these studies were done in developed countries with health system and clinical care characteristics that facilitates the diagnosis and follow-up of patients. For the date when this study was designed, there was few information about active surveillance in developing countries, which imposes some specific conditions of management and follow-up that will be discussed later. So the objective of this study was to present the experience of active surveillance in patients with thyroid nodules classified as Bethesda 5 and 6 in Colombia. And since January of 2015, we assembled a prospective cohort of patients in a Colombian center dedicated to treat head and neck tumors. The candidates were adult patients with an ultrasound diagnosis of thyroid nodule and a result of fine needle aspiration biopsy classified as Bethesda 5 and 6. All these patients were sent to our center with an indication of thyroidectomy by family physicians, endocrinologists, and general surgeons. In Colombia, the health system is divided in two big groups, one subsidized by the government and the other paid by patients. Therefore, diagnostic tests are made in different sites, which make centralization very difficult. It implies that most results come from non-specialized diagnostic units, and this point is very relevant in the discussion of active surveillance as an alternative in developing countries. The inclusion criteria for active surveillance follow the previous indications from ITU and TUTL studies. Initially, we included only patients with interthyroid nodules smaller than 1.5 centimeters and without any adverse ultrasound features, suspicion of central or lateral lymph node metastasis or extrathyroid invasion. But later, we decided to include nodules larger than 1.5 centimeters in patients older than 65 years old that have medical comorbidities which were classified as high risk for surgery or who expresses their willingness for alternatives other than surgery. I believe that the most important aspect of this study was the method to present the alternative, and therefore I am going to explain it deeply. A specific design of the decision-making process was done. This process was divided in 3 steps. One, during the first visit, the second after choosing active surveillance, and the third during follow-up. I consider that the most important step is the first one. During the first visit, it is necessary to solve 3 critical points. One, to control the patient's anxiety for the diagnosis. Second, to provide information about treatment alternatives in a neutral way. And the third, to make the decision. So, to control the anxiety, it is necessary to explain to the patient carefully about the available information on internet and social networks, and to point out more reliable data. Most patients come to the first visit with a lot of information about thyroid cancer that influence his decision, and it is clear that most of these sources only offer surgical treatment. Second, it is necessary to clarify the difference between risk of malignancy and diagnosis of malignancy. In front of a thyroid nodule with a cytological result suspicious of malignancy or malignant Bethesda 5 and 6, it is necessary to explain that a definitive diagnosis can only be made after surgery. Also, it is very important to explain that Bethesda classification is not about the stage of the disease that most people believes, but about the certainty of the pathologist who evaluates the results. And also, I think we must use more exact terms as suspicious nodules or high-risk nodules instead of using the term cancer. Third, I explained the concept of overdiagnosis and incidentaloma and the relationship between the symptoms the patient experiments with the thyroid finding and the low possibility that a nodule smaller than 1.5 centimeters can produce most of these symptoms. I also talk about the inconvenience of making thyroid nodule screening. And finally, and the recommendation of not making fine needle aspiration biopsy if the nodule is smaller than 1 centimeter. Fourth, I give specific information about the risk of malignancy related to the ultrasound findings and fine needle aspiration biopsy results. I think all these steps help to decrease the patient's anxiety and to put him or her in a receptive mode to interpret and understand the information about the alternatives I am going to offer. The second phase consists in a provision of information of treatment alternatives in a neutral way, and I think that this is very important, neutral way. As I am a surgeon, usually you try to support surgical treatment, but we have to control it and to put it neutral. I follow a specific order, offering active surveillance as the first alternative. I explain the logistics, how it is going to be done, what's the periodicity of the examination, what's the time of follow-up, when will the surgery be necessary, its extensions, and the risk related specifically with recurrence. After this, I expose the information about surgery, thyroidectomy, explaining the type of anesthesia, operative time, the extension of surgery. For example, I explained that I make a lobectomy in those unifocal tumors smaller than 4 centimeters with favorable findings, and a total thyroidectomy in the others. The risk associated with surgery as recurrent laryngeal nerve injury, hypoparathyroidism, bleeding, and finally, the probability of thyroxine support in the long term. After this comes the phase of making the decision. Some factors as age lower than 40 years old, the constant fear of the patient about cancer, and a strong preference for surgery are relevant to choose thyroidectomy. On the other hand, fear of surgery, discipline and logistic possibilities for long-term follow-up that is important in developing countries, and preference for an alternative that decrease the risk of thyroxine support are very relevant to choose active surveillance. I consider it important to realize that Colombia's health system, as in other developing countries, is different from systems in developed countries. We have problems with the access to medical attention. Sometimes the attention is restricted or can take a long time. For example, we have a lot of patients who live in far rural communities where active surveillance could not be the best option. After the patient chooses active surveillance, I usually recommend to discuss with his family because this is a very important factor to maintain the decision. I also mentioned the possibility of changing his decision, his mind during follow-up without any feelings of guilt or blame, even if this occurs before the next visit. What I have seen is that the switch to surgery occurs frequently during the first 4 weeks after the decision. And the patient must feel the trust to come back and change his decision based on non-medical factors as fear, for example. Therefore, we collected data about demographic and clinical information, ultrasound features as size, volume, findings, the reasons to operate the patient, and the time from the decision to the last control or the date of surgical treatment. We recruited 102 patients. Most of them were women around 50 years old, and a majority had an incidental finding of a thyroid nodule. 75% of nodules were smaller than 1 centimeter. 77 were classified as intermediate and risk by the ATA ultrasound risk classification. 2/3 of patients had a result of Bethesda 5 suspicious of malignancy. And in most cases, the reason to propose active surveillance were the findings of nodules smaller than 1 centimeter. The mean time of follow-up was approximately 21 months. We found that 62% of patient nodules remain stable or even decreases in size. And I think this finding is relevant because there is a belief in medical community and between patients that suspicious thyroid nodules only growth. Most of them remain stable. Only 11 patients showed an increase in diameter larger than 3 millimeters. And as you can see, the Kaplan-Meier graph demonstrated a nodule stability of 89% at 24 months. Even when classified by age, the growth rate was very similar to those reported by Ito studies. Only 13 patients underwent surgery. In all cases, a papillary thyroid carcinoma was diagnosed. 8 of these patients were operated based on nodule growth, and 5 were operated based on preference, usually patient preference, but also in surgeon preference. 5 of them required a lobectomy, and a majority were operated during the first year of follow-up. The Kaplan-Meier graph, as you can see, demonstrated a stability without surgery of 85% of 24 months. An interesting finding of this study was the lack of agreement between growth larger than 3 millimeters and an increase in volume larger than 50%. The volume increase overestimated the diameter growth by almost 17%. So for discussion, I think that this study showed that active surveillance is possible in developing countries, even with major differences in health systems and healthcare structures. Besides, one of the objectives was to evaluate if active surveillance could be done outside academic centers, and we confirmed this assumption. As I mentioned, most patients were sent for thyroidectomy, and we tried to explore and propose a new alternative, active surveillance. We could do it. These results have also been validated by studies done in Argentina and Brazil. Second, these results are similar to those reported in other studies in developing countries as Japan, United States, Italy. And this confirms the reproducibility of the alternative in different economic, social, and cultural settings, even in the presence of several administrative limitations. The other relevant finding was that diameter is a better indicator of growth than volume, and that the use of volume could overestimate the clinical behavior of the nodule and could produce overtreatment in these patients. Finally, I believe that these results confirm that the success of active surveillance is based on a long and dedicated discussion with the patient about the pros and cons. the provision of neutral information about the alternatives, and an open support for the decision the patient make. I want to thank for the opportunity to present these results, and you all always welcome to Medellin. Thank you.
So, good morning to everyone. Thank you again, Dr. Brito and also Alvaro, for the invitation to be here. For me, it's really a great pleasure and a honor to be here with you today to discuss active surveillance in Latin America. So when I received this invitation, I was thinking about what exactly I could comment about this paper from Alvaro. And I decided to go to the other side because Alvaro, he showed us his very interesting and also successful implementation of the active surveillance here in Latin America. And we are also trying to do this here in Brazil, but we are facing a lot of challenge and also some barriers. So I decided to bring it here and to discuss with you and show this challenge and also maybe discuss some prospects and to see if it's going to get bigger here, the implementation in South America or Latin America. So I have no conflict of interest for this presentation. And as Alvaro already has done this introduction, right here. As Alvaro has already done the introduction, I will just skip here to the discussion. And I think this framework proposed by Brito seems to be maybe the most objective way and I think the practical way to initiate or to decide which patient is the best one to go or to start active surveillance. So I'm going through these 3 points and discuss our most barriers that we are finding here and maybe discuss some solutions for these problems. So about the clinical findings and the nodule characteristics, I think this data, our Japanese colleagues, they have already shown us very robust data, and we can see that the follow-up of these nodules are really very it's feasible, and we see that in 10 years almost or more than 10 years of follow-up, we see that these nodules grows at a rate of maximum of 10%. And according to the lymph node metastasis, most of them in the highest number here, 3% will show lymph node metastasis. And until now, no one of these nodules under active surveillance showed distant metastasis or even mortality. And outside Japan, we have also the data from Professor Turtle's group, and he has also confirmed this data. So a nodule growth rate about 4%, no lymph node metastasis, and also no distant metastasis. And similar data was shown by Molinaro, also with a growth rate about 3% and just 1 lymph node metastasis because of an aggressive histology of the nodule. And here in Latin America, we have also 3 published papers. The first one was from our president here from the Latin American Thyroid Association, Fabian Pitoia. So in his group, he has shown that it's also possible to do active surveillance here in Latin America. But one point that he has shown is that maybe the nodule growth by his group was a bit higher. So we have maybe to confirm this data if maybe the nodule will grow more here in Latin America. But Alvaro has shown his data, and in his almost 4 years of follow-up, he has about 10% of nodule growth, also without any lymph node metastasis or distant metastasis. And here in Brazil, we have also one publication yet. It's from the group of Pedro Rosario. And he has shown that just 1 out of 70 nodules had to go to surgery because of nodule growth. So it seems that the nodule behavior is similar to the others around the world. Maybe we have just to prove if this nodule growth is really a bit higher or not. Well, I'm going to show a bit about our experience here in Brazil. Alvaro has already shown here a bit about the health system here in Latin America, and in Brazil is similar as we see in the rest of Latin America. So we have here 2 kinds of system. One is the public one, and the public one, every citizen has access to this public health system, so you can go to every public hospital, and all the doctors that works there, you can get access to these doctors. So first you have to imagine that São Paulo, only São Paulo, the city of São Paulo, has 21 million of inhabitants. So if you go to a public center like this, you will find a lot of people. So normally it's really very full of patients there. And on the other hand, we have the private system, and the private system, it's subdivided into 100% private. And in this 100% private, the patient pay everything by his own. So he can go to every hospital he wants, he can go to each doctor he wants and pay by his own. And we have also the health insurance, and the health insurance, you pay for it, and then, but you have limited certain places to go, just certain hospitals that you can go, and just go to doctors that are certified to that insurance only. So this is a slide overview about the health system here in Brazil. So we are trying to do active surveillance in these both centers, not only in a public hospital, but also in these 2 private assistants. And in the public hospital, it's an academic center from the Hospital of Santa Casa. We are doing active surveillance for more than 4 years. And what we receive, the patient that come to us, they're normally low-income patients, and they normally don't do these checkups, or it's rare to do preventive medicine. So normally when they come, they have already a clinical disease. So it's really seldom to find these patients with incidental findings from microcarcinoma. So in these 4 years, we have only 7 patients under active surveillance. The median age is 66 years old, and from the 7, 4 had to drop out of the follow-up, 3 because of nodule growth, or 1 of extra thyroid extension, and 1 because of anxiety. And on the other hand, we have the patients in the private hospital. In the private hospital, normally this patient, they have a lot of finding of this incidental microcarcinoma because they do a lot of these checkups, and they search for something about active surveillance. So they find it at internet, and they come to our center. So they look for us. So normally we had already about 20 patients that look after active surveillance, but because of nodule location, we could not start active surveillance with these patients. And then we have now 9 patients under active surveillance. These patients are a bit younger than that on the public center. And until now, we had just 1 dropout, and it was a finding that it seemed to be there, an extra thyroid extension, but she get operated, and the final histology didn't confirm that she had this extra thyroid extension. So it's easier to do this active surveillance in this private center. So it seems because we started to do this active surveillance, and we started to find a lot of barriers, we thought to do a survey and asked the doctors here in Brazil, not only endocrinologists, but also head and neck surgeon, what they think about active surveillance. So we sent a survey. It was a snowball sampling survey, and we sent it through these WhatsApp groups. We have big groups here to discuss thyroid disease, and it's a big group from endocrinologists and head and neck surgeon. And we sent this survey to this group, and there were 7 cases, clinical cases about active surveillance. And the result for us was a bit surprising, because of the 657 doctors who answered these questions, and almost all of them still perform fine needle aspiration nodule biopsy in nodules less than 1 centimeter. And only 23% of these doctors, they offer active surveillance to these patients, and 77% that recommended surgery. 58% total thyroidectomy was recommended for all these cases. So we see that the doctors here in Brazil are still more for surgery, although we have here published here in Brazil our one guideline, or it was an expert's opinion, was published in 2019. And it was recommendation how to deal with this microcarcinoma. And in this recommendation, it's written that we have only to perform fine needle aspiration biopsy for these very suspicious nodules. The recommendation 2 is to start with active surveillance, or active surveillance should be the best option or a better option than immediate surgery. And if surgery is recommended, lobectomy should be the best option. So although we have this, we can see that our doctors here, they're not following exactly what we are suggesting them. So what we faced of problems during the analyzing this medical team is that in a public environment, we have very few specialized centers, and these centers, they are more academic centers. So the people that are doing active surveillance here in Brazil in public centers are only these academic centers. We have also very few multidisciplinary groups, and we know that if you work in a disciplinary group, it's easier and it's more feasible to do this active surveillance. And more, with this patient in a public environment, we have also little access to periodic ultrasound, and it's very seldom to do with the same examiner. So these are points that we know that it's very important to do active surveillance. And I think here's the most important point, and it was the focus of the presentation of Alvaro. He said that we have to dedicate a lot of time talking to these patients. And one big problem is we have a lot of patients there, so the duration of these appointments are not so long. So we have to dedicate more time explaining this to this patient, because they can't imagine what is active surveillance. So we have really to dedicate more time explaining this to the patients. And on the private group, on the other hand, we have one advantage, that is the patient has many personal doctors. So when we offer active surveillance to this patient, they normally comment this with the other doctors, with the gynecologist or with the other doctors, and they come back and say, oh no, my doctor said it is crazy, so not, I want to get operated because this is really crazy. So we get a lot of influence about these other personal doctors from the patients. But we have also some advantage, and the advantage is they are patients that is easier to make the follow-up. For this patient that pay everything private, it's much more cost effective for them. And also we have good access to high quality ultrasounds. And now about the patient characteristic. Here in the public center, as I said, we have a high volume of patients, But normally this public, they are really, they have a very low income, so they have not a lot of information, especially about cancer and more about active surveillance. So normally when they come, they had never heard before about active surveillance. So we have really to dedicate much more time to explain them. And a very important point is that it's much easier to lose the follow-up of this patient because a lot of social adversity that this patient have. And in the private patient, they have much more access to information. It's easier to clarify the question or to explain what's the objective of doing active surveillance, and they have much more commitment to the treatment and also to the doctors. And here in Brazil, after starting to do this active surveillance, I learned to know a typical profile of patient. It's the mystic one. So I don't know if you find this in United States or in other countries, but here in Brazil, a lot of these mystic patients, they come to us, and I learned that the thyroid is one of the chakras that we have here. It's a point of energy. So they really don't want to get out. They don't want to lose their thyroid. So it's an important part, because if they get operated, maybe this point of energy is going to be disrupted. So it's the kind of patient that come and looks after this active surveillance. So to conclude my part here in the discussion, I think the point that Alvaro brought us here is his successful implementation, and he had 102 patients that are under active surveillance. And I think the main point that he showed is the way we have to talk to the patient, and also the access he has to the patient. And maybe he does everything by his own. He does ultrasound by his own. So this is very important. So if we want to make more active surveillance here in Latin America, maybe we have to improve these 3 points. So we know that it's not easily accepted until now, but we know, according to the images, that maybe if we do multicentric studies here for Latin America, we will have more data, especially about this growth rate, and confirm if it's really a bit higher than the other countries or not. According to the patient characteristics, I think we have to make more patient education. We have to clarify the risk, and I agree with Alvaro, maybe we have to change the way we are calling these cancers. Maybe we have to change the name by suspicious nodules, and we have really to explain the difference between low risk and high risk microcarcinomas. And we have to dedicate more time to talk to the patients, and this will arise this commitment to the doctors and also to the follow-up. And finally, here to the medical team, I think we need urgently to do medical education to show not only the endocrinologists and head and neck surgeons, but also the other medical, the family doctors and also general doctors, that active surveillance is feasible and it is very secure. So we can do it, and it's not, immediate surgery is not the best option for this low risk carcinomas. So we have to adequate the infrastructure to do active surveillance. Maybe in the centers we have to do ultrasound training for the endocrinologists and even for head and neck surgeons. We have also to adequate the infrastructure for public centers, facilitate the agenda for these patients. And I think a lot of these points need to be improved. So if we improve all these points, I think active surveillance here in Latin America is also very possible. So I want to thank again Dr. Brito and also Alvaro for the invitation to be here. This is our group in Brazil. Here in Santa Casa is our public hospital where I work. here I have also my students, and they're working hard and looking for some molecular markers for these microcarcinomas. And we have also this private hospital, Samaritano, where I work there with Dr. Bertelli. He's a head and neck surgeon, and we work also together there. And I want also to thank you for your attention.
Thank you, Dr. Ferraz and Alvaro. Wonderful presentations as well. I do have some comments on your presentation and questions that it's amazing the several cohorts that are happening in Latin America in regards to active surveillance. When Alvaro, you presented your data, and I was very impressed with the decision-making process that you have. Is something that clearly is patient-centered, which I think might speak volumes in regards to how much thoughts have you given to the process. It also makes me think that from the patient's perspective, having a surgeon telling them that watching is possible has a lot of impact on decision making. So what are your thoughts about from the clinician surgeon perspective? Do you think having you as a surgeon versus an endocrinologist like me or Carolina saying active surveillance doesn't make a difference?
Yes, I think it makes a difference. What I say, or what I see really, is that some clinicians are very aggressive with the treatment of these small nodules. So when the patient goes, because the patient usually goes first to the clinician, family physician, endocrinologist, internal medicine, they push the patients to an aggressive treatment named surgery. And when people comes to me, I have to wait to try to explain, to try to stop this idea that the best treatment is surgery. I think that being a surgeon obviously puts an influence on the patients that clinicians could not have, but I don't think that it is the only factor. I feel that the most important factor is to believe that active surveillance is possible. Because what I see is that usually clinicians see the cancer in a way that is different from the vision we surgeons have. Yeah. As I am a head and neck surgeon, I have to try very aggressive tumors of mouth tumors, larynx tumors that grows rapidly, have a lot of lymph node metastasis. And when I compare this patient with thyroid nodules, I can see a difference. And for me, it gives me, what do you say, some kind of less expectation of doing an aggressive treatment. I think that clinicians should go with surgeons to see the differences that are in patients with this low risk thyroid carcinoma, because it will give them the trust to sustain more stronger decision of making active surveillance.
Yeah, no, I do agree. Carolina, you presented some data from your survey, which is a little bit different. I mean, because and this is actually consistent with surveys that were presented by a colleague in China the last time. Is that comparing to endocrinologists comparing to surgeons, endocrinologists are more likely to recommend active surveillance, but it seems to be that is in specific clusters of endocrinologists. It seems that you do work closely in a multidisciplinary team. How do the conversations with active surveillance go in your institutions? Are you the one driving this, or is also your ENT surgeon on board, or your endocrine surgeon also discussing this with the patients?
Yes, we have in our public center, we are divided. So we have the endocrinologist and the head and neck surgery. We don't work together there. So but the group of head and neck surgeons there in Santa Casa, they already know this protocol and they are working together with us. I think exactly because of Alvaro said, can you imagine the huge amount of a surgery they have to do for this big cancer, for this big lump that they have in the neck? And they really put just in the end of the line these microcarcinomas to operate. So they really want to send us to do active surveillance for this patient. And in this public center, it's really rare to find these microcarcinomas. In the other center, the private one, I work together with I'm sitting together there in the consultation room with my head and neck surgeon. So I noticed that this commentary that you've done to Alvaro in the beginning, it's very important, because when the head and neck surgeon offers the active surveillance, the patient is much more relaxed, and then he say, okay, if a neck surgeon is offering me this, so I'm sure that it's really nothing so urgent that they need to operate. So I think working together in a multidisciplinary team enriches a lot the acceptability of this active surveillance.
No, I completely agree, and that's probably also why the active surveillance protocol at Memorial is also very successful. Also driven by now it's driven by endocrinologists, but in close partnership with surgeons, and actually the surgical group was at Memorial the group that started active surveillance, and they taught the endocrinologists how to do it. And I think the multidisciplinary nature speaks a lot about working together and having a common language, and patients perceive that as useful, as being, at least to have some peace of mind regarding, oh, my team agrees. But because what happens sometimes is patients hear active surveillance, and Carolina, you suggested they leave the encounter, they talk to the gynecologist or anybody else who, by any means, is understandable. They hear cancer and say, are you crazy? Are you not going to watch this? And in my practice, I have had many instances in which the radiologists were actually the ones saying, why are you watching this?
Yes.
And as soon as they hear that, they come back to me and say, do something about it. And it changed the whole dynamic. So
yeah,
I can clearly see that. Yeah.
Yeah, I think that's exactly the point that Alvaro said. That's why we have not only to show this data to the patient, but we have also to welcome this patient, to make this make this patient more comfortable, and to explain him all this data and the security about active surveillance. And this is also the point why we have to make more classes and amplify this medical education about active surveillance. I think we have to do a lot of work explaining active surveillance, because we know active surveillance is only feasible in a very few number of types of cancer, prostate cancer or thyroid cancer. So I think we have to spread this idea. This is the point, because we have really a lot of these barriers, and normally when we start to do active surveillance, we already make this alert to the patient. We say, okay, you are going to your gynecologist and he's going to tell you that you are crazy to do active surveillance, but take a look, it's not like this. And then we start to do this patient education with our patient who is going to go under this active surveillance. And we try to do something similar that Alvaro is doing, to invite the family or to explain more about this active surveillance to the family too, so that they can also help us to spread this idea about the active surveillance.
Yeah, I think a lot of what you're doing is very smart way to avoid that. Certainly, that's people make decisions in their network, in the context. So family certainly is a big player. Alvaro, you mentioned that you are in your cohort, you are including patients above with tumors larger than 1.5 centimeters when they are older than 65. What is your experience with that, given that that's not the traditional cutoff for active surveillance?
In fact, we started it without knowing that we were making active surveillance. A lot of people, older people, have many incidental findings in the thyroid gland because they underwent a lot of exams for other reasons. For example, carotid stenosis or dysphagia or something like that. And most of them came to the visit asking for something to do. But I think that older people have a different side of their life. And when you talk with them, they can see clearly that this is tumor that was found incidentally will not change anything about this future. Maybe could introduce a lot of noise in the treatment of the other diseases like hypertension, diabetes, arthritis, etc. So I believe that when we were doing active surveillance without knowing it, when the concept was introduced, I see clearly that it is possible to offer to them, and I think that they get a great advantage because they are not at the risk of a surgical procedure. To operate a patient older than 65, 70 years involves a lot of inversion in the surgical tests, evaluation by cardiologists, by the pneumologists, by other people, and you will only change the ultrasound because the patient don't see anything, don't have anything in the thyroid, and I think they are more receptive of this approach. And I would think that we should offer most to these people. I always still see a lot of patients older, yeah, I'm saying older than 80, 85 years, who comes to the consultation to make the follow-up of a thyroidectomy done before. And I can't understand what was the reason to offer it to a patient that where the nodule is not going to produce anything, and as a surgeon, I'm not going to offer any advantage for him.
Yes, no, that's important. The contextualization is certainly important. One of the reasons that might be challenging, and this is a question from the audience, is that in order the challenge to offer active surveillance is that the process of finding the thyroid node to happen outside the expertise of might happen. It might happen by internal medicine, family medicine. They find a nodule, and they are already set up a pathway of care that usually brings a lot of anxiety to the patients. So the patient already come with a lot of anxiety about a lump, and then tuning down that anxiety is challenging. I think you, Alvaro, you did speak about this. I also find this as a difficult challenge. Carolina, what did you process to trying to bring these patients on board to have a conversation about perhaps active surveillance as an option?
Well, let me just check if I understood your question. It's just to what I do normally with this patient that come to me with the diagnosis of cancer, and they come already with the indication of surgery, and what I do to convince them to active surveillance.
Yes. I think it's exactly, yeah. The patients come with either the lump or the diagnosis and they have a lot of anxiety because the conversation happened outside. Yeah. So Alvaro did suggested, he works closely with information as a way to overcome the anxiety, which I think that's what majority of people do. But sometimes we don't pay attention to anxiety. So what has been your experience on that?
Yes, it's like I think it's the same everywhere. I think we are noticed this in maybe not in Japan, but I think in USA, also in Europe. I think all patients come with this idea that maybe this cancer is going also to spread, and we try to explain and show this, especially this Japanese data, and show how feasible it is, and we start just to to tell really a history. And Japan, 20 years ago, they started to make the follow-up of these nodules. So we start and then we notice how this patient is. I think it depends really on 2 points. First, on the way the doctor speaks with the patient, and also the way the doctor is. For example, I'm a very minimalist doctor, so I'm very calm. I think Alvaro is also very calm. But we have a lot of head and neck surgeons here that said they can't believe in active surveillance. They say no, because I think especially head and neck surgeons, they are they studied to solve problems. So come here, I'm going to solve your problem. They cannot accept, come here, and then you come back here, and they're not solving your problem. So maybe this is the most difficult part. And me as a clinician, especially as endocrinologist, I rare or seldom can solve the problem for the patient. I can control, I can manage these problems, but to cure diabetes or to cure obesity, it's really very seldom. So what I try is just to convince that maybe this is the best way for him now. And a very important point is to say that active surveillance, it's not forever. You can drop out the time you want, or maybe it's just a bridge that we are doing now. And if you need to operate, or if you want to get operate, we can do it anytime you want. And I think this is also important to tell the patient. And if he has the opportunity to get out, if he wants, I think it leaves him more relaxed doing active surveillance. So I think it's really this long talk that Alvaro focused in his presentation. We have to focus more on this psychological part of the patient now than trying to convince him by numbers. And I think we have really to touch this part of the patient.
No, absolutely. One thing that I don't see often reported in the active surveillance cohorts is the acceptance rate of the, imagine 100 people that are candidates for active surveillance. What is the percentage of people who ended up having active surveillance as a management? Do you have that data, Alvaro? And let's start with you, Alvaro, and then with Carolina.
No, I don't have the exact data, but I think that only 20% of people accept the option of active surveillance. Almost 20%. Most people, what I've seen is that maybe 50 or 60% of people accept in the first visit. When they go out to talk with the family or to talk with other doctors, they come back and say, okay, I change my mind, I want you to pay it. And I say, okay, no problem. I think that this part of not making the people feel guilty or blame because they change the decision is important, because I think it gives trust to the patient. And these patients, for example, a couple of times they came back with his mother, for example. She doesn't want to operate. I want you to see her, because the person feels that we are not pushing him, we are just making a shared decision.
Yeah. Carolina, what do you think? This 20% also applies to your institution?
Yeah, I think it's about that. But another problem that we find here is some patients that they come to us because other doctors, they send this patient to us because they don't have a center to make this active surveillance. So they send us this patient and say, this may be a candidate, can you please see this patient and see if it's possible to do active surveillance. And about half of these patients, we have also doubts because, for example, when we see the data from Japan, what is described there? The nodule next to the trachea or also next to the nerve, it's difficult, it's not possible to make active surveillance. But, and what about these nodules near this capsula, this anterior capsula? We have not a lot of data of that.
Alvaro, can you hear me?
Yes.
Sorry?
Yes, we are hearing.
Yeah. Sorry, Carolina, I lost you for a moment. You were breaking up a little bit.
Okay.
But yeah, if I got it, was the idea of
Yeah,
selection bias.
Yes, I think we have to get also more information about other positions of the nodule in the thyroid. For example, we sent 2 patients to surgery because they were located near this anterior capsula, but then they got operated and there was no extrathyroidal extension. So we don't have description of this on the guidelines. So maybe we have to inform more about these other locations of the nodules and to get more information about this too. So I think it's about 20-30% patient that we can do active surveillance based on this location of nodule and also characteristic of the patient.
Yep, absolutely. And we are running out of time. Here is at the end of the hour. I would like to thank you, Alvaro and Carolina. Fantastic presentations. I really want to say thank you for your time, and also invite our audience to join us next week for another virtual journal club. We're going to have Dr. Giovanella talking about procalcitonin as an alternative tumor marker for medullary thyroid cancer. So we're looking forward to seeing you, all of you. And again, thank you very much.
Thanks.
Thank you.
Okay, bye.
Bye-bye.